There we go. And now I will give you control.
Awesome.
And it still says it's showing my, oh, keyboard mouse. I need to give you the screen too. Yes, I'm sure I want to make you the presenter.
Okay.
Of course, my mouse broke this morning.
There we go.
I'm a little, okay. There we go. You have power.
Yay! I have the power. Okay, so I'll go ahead and get started. And as Kirsten said, if you have, if you want to raise your hand, ask a question, make a comment, please do so. We're very flexible and would love to get feedback as we're going along. Webinars are always a unique experience, and I can't see you to know, like, if you have something to say. So feel free to do that on the little panel next to your screen. So like she said, my name is Megan Jones, and I am with the Integrated Services Project. And we're so excited to do this webinar today. Thank you all so much for coming. You'll see that we're very passionate about this work, and we've been doing it for a long, long time. So we're happy to be able to pass along the knowledge that we've gained, and then also what we've learned from advocates such as yourself out in the field doing this work. To give you a little bit of history about myself, I have, like I said, I've been with the Integrated Services Project since the beginning when we were starting with research, which we'll talk about in just a minute. I started out in the field as an advocate, doing domestic violence and sexual assault work, and then did some clinical work as well in the substance abuse field and the mental health field. I'll let Silvia introduce herself.
Hi, well, I'm Silvia Benitez, and I also have history on domestic, and as an advocate, I started being an advocate in 2008, and in the region of Linn County, the county, and I was a rural county and also the Hispanic advocate there. I was advocate for 5 years, but once you put that hat on, it's never off. And after that, I move on to start helping people with problems on addiction, alcohol, drugs, pills. And so now I am a certified substance abuse counselor. And with when I started with ISP, it was the perfect combination because I had those two. That project will put together those two issues, and that is domestic violence, sexual assault, and substance abuse all together. And that was what I really wanted to do. So, yeah, that's me.
So we wanted to talk a little bit about the Integrated Services Project. And I apologize for those of you who are familiar with the project and have been working with us. This is a review for you, so I do apologize about that. But for those of you who are unfamiliar with ISP, we wanted to give you a little bit of our history and then also put in context where we get our information from and the work that we've done. So in 1997, we started the initial research project, and this project was through the University of Northern Iowa. Dr. William Downs, Dr. Bill Downs, was the principal investigator, and he co-presented with our other team member, Barb Brindles, at the last webinar. So we encourage you to take a look at that, as Kirsten had mentioned at the beginning. And we knew anecdotally from advocates and counselors that there was a co-occurrence of intimate partner violence, sexual violence, and also substance use disorders. However, there was not a lot of research done in this area. In fact, the research was and continues to be a little on the skimpy side. So we really wanted to set out and find out what is going on, where is this co-occurrence happening, and what percentage. So we went to central and eastern Iowa and talked with clients and staff in 9 domestic violence and sexual assault programs and 7 substance abuse agencies across Iowa. There was 446 interviews, I think. I always forget that number, but it was about around there, interviews that we did with women. And here is what we found. So this is women reporting in substance abuse treatment programs. So they were receiving substance abuse treatment services when we did the interviews. About 67% reported physical abuse 6 months prior to coming to treatment. About 93% reported that they experienced some sort of psychological abuse 6 months prior to coming to treatment. And about 90% of women in substance abuse treatment reported partner abuse in their lifetime. So what I like to tell counselors is that 9 out of 10 of the women that you see have some sort of domestic violence and or sexual assault in their history. And then conversely, when we talked with women who were getting services from domestic violence, sexual assault advocates, either shelter services or some sort of outreach services, about 26% reported or met the criteria for alcohol dependence, and about 39% reported some sort of drug problems with their drug use. So that is a total of 65% of women in receiving outreach or shelter services reported some sort of problem with their substance use. Now, we actually think that that statistic is on the low side, and I'll tell you why. The way that we did the interviews was we would come to group or shelter at a meeting or something like that and say, hey, would you like to be a part of this research project? And they'd say, sure. And then 3 days later, we would come back to do the interview. Now, at the time, most shelters had a no-use policy, so you could not use while you were in shelter. And what happened was that we missed a category of women that had addiction problems. There's no way, if you have an addiction, there's no way that you can wait 3 days in shelter without using for a research interview. So the national trends that we see is about 80% of women who receive outreach, receive some sort of domestic violence service or sexual assault service experience substance use disorders as well. So about 8 out of 10. So we took this information back to the agencies that were involved with our project. And while they weren't surprised that there was a co-occurrence, they were surprised at how high it was. And they basically turned it back to us and said, you know, what are you going to do about it? And in addition to that, a lot of the research that we did was qualitative, which means we would ask open-ended questions such as, tell us the worst incident, tell us the first time that this happened, things like that. So women really were pouring their lives out to us and giving us a lot of information. Sometimes the interviews would last as long as 4 hours. So we made a promise to them that we would come back and change services. So the Integrated Services Project was born, and our mission is to enhance safety and sobriety of substance abusing women by ending service discrimination. Sorry about the paper shuffling in the background. And since then, so we started this project in 2001, and we have worked with 38 agencies across Iowa, and these agencies cover 81 of Iowa's 99 counties. And here's a list of all the different agencies that we've worked with. Some of them are no longer open, but we certainly want to give them credit for all of the great work that they did with us when we were with them in the project. And we've learned so much from all of these agencies and their staff about working in that joint space of trying to help women in their safety and sobriety. So before I turn it over to Silvia, I did want to talk about a couple of stories to kind of put in context also why it is so important for assessment. One story, the first story I wanted to talk about was my own. So I started, as I mentioned, I started in the field as an advocate, and then worked as a substance abuse counselor and mental health counselor. And so as a substance abuse counselor, once my supervisor found out that I had this background in advocacy, I got all of the victim survivors that came through the door. So I had a very, a big caseload. And one woman that I was working with, she was part of her aftercare treatment was to come meet with me individually. And she was doing really, really great. She had left her abusive partner. She was in a halfway house program. She was going back to school. She had a good paying job. She had childcare and school for her kids. She just, in addition to going to treatment, going to meetings. She really just was doing so awesome. I was so proud of her. And so when we initially started meeting, I asked her, you know, what are some things that I can look for to tell me that you might be struggling with relapse? And she said, oh, hygiene. Like if I stop showering, if I stop taking care of my hair, if I'm not dressing as nice, those are all signs that I'm starting towards relapse or relapsing. I said, okay. And as we're, you know, moving along working, she came one week and she wasn't looking so great. She wasn't dressed as she normally was, looked like hair looked a little unkempt, but you know, we all have those days, so I kind of let it go. And then the next week when she came in, she looked even worse, and I thought, okay, I can't let this go. So asked her, you know, hey, you mentioned in the beginning that these are some things that I should look for. And I'm seeing this in you. And of course, as a substance abuse counselor, I'm thinking relapse, relapse, relapse. And she burst into tears and started talking to me about how her former partner and abusive partner was calling her all the time, calling her in the middle of the night, threatening to come take her and the kids. And she was so worried about her safety and her kids' safety. Now, had we not had that initial conversation about that abusive partner, I would have, and she felt trust in me and feeling open to talk to me about that, I would have completely missed it because I had my substance abuse counselor hat on. I was only looking at substances and the potential for relapse. So, and another story I wanted to share too was actually came out of the research. One of our team members was at a shelter and shadowing a shelter meeting, and the shelter staff were talking about a concern that they had for a client that had just come in, and they said that when she first came in, she was just amazing, just really happy and bubbly and cleaning the shelter and helping out in all these different ways. And then suddenly she was sleeping and was sleeping for truly like 2 or 3 days straight. And so the staff were like, oh no, she's depressed and she's really, you know, she's going downhill. And the team member that was there was like, you know, have you assessed for substance use? I wonder if maybe something. And sure enough, once they talked with her, they found out that she was coming off of meth and she was going through a withdrawal. So again, if we don't ask the question, if we don't set up that comfort level that this is a safe place for you to talk about anything with me, how are we ever going to know? I'm going to pass it along to Silvia.
Well, wow, Megan, it's just unbelievable, right? The numbers that you just gave us are really eye-opening to all of us, because just to know that women in treatment, that 9 out of 10, they do have some history of domestic violence. Well, that is really, really high. And women in shelter services, 65% will have some sort of substance use. So that tells us a lot. That tells us that indeed, you know, this is a problem, and this is a health issue, and this is something that could actually put in danger our clients. So yeah, great research. Well, today I'm going to start talking about why to assess. You know, what is assessment, but what to assess. And the first thing is substance use prevalence. You just mentioned the numbers. 9 out of 10, you know, in treatment has some domestic violence history, and 65% in the shelter will have some sort of substance use. Well, as you already know, and based on the ISP research, there is a co-occurrence between the abuse of substances and domestic violence. Whether your client has previous use before domestic violence, it is really not relevant. What it is important here is to know that during and after domestic violence, individuals will continue to use mostly as a coping mechanism. Traumatic events in anyone's life calls for the stopping of suffering and pain. This pain can be as real as broken bones, bruises in any part of their bodies, or can be an emotional and psychological pain. Pain that sometimes is challenging to recognize or reveal to others, right? Well, drugs and alcohol then can be the best friend that will never fail and will take care of the pain and will all of them to numb, okay? So links between safety and sobriety. Some good examples to understand the link between sobriety and safety will be if we think in terms of consent. Have you ever seen the video T Consent? Well, I highly recommend it to you to watch it in YouTube, T Consent. As we all know, advocates have very clear that if the person is intoxicated, can give consent. But abusers use this vulnerability to their advantage. And they prefer to have a victim intoxicated or high than sober. And we think that we all know why is that, right? Because they really cannot defend themselves as well, or make fast decisions, like flee the scene. They might be intoxicated. They might be actually so drunk that they cannot really walk, or they can put their lives in danger if they're going to drive, while intoxicated. Well, if we think in the same terms, we can help our client explaining her the advantages of being sober. Client will have a better chances of remembering the safety plan that you two will create while you're together. Make better decisions and not risk the life of her children or her own life or someone else's life if she is fleeing the scene and she probably is under the influence while driving. You also can talk about if that person is not yet ready to quit completely, well, this is also the time to say, hey, what about reducing your use? This also can actually be very helpful, for your client to say, well, she understands and she wants for me to be healthy. And not just about health, it's about safety. So safety and healthy both goes together. Now, research from agencies who assessed and those who did not. As you know, they actually did a lot of interviews. ISP did interviews while performing the research. Well, clients were asked many questions. One of those questions was specific to know if advocate had asked any questions about their use during the time that they were talking and providing any other services to them. Some individuals reported that they were asked about it and they felt relief as they didn't have to keep their use as a secret. That's a very important point. They said they felt safe talking about it and were able to get some help afterward. On the other hand, some individuals reported that despite they were using, advocates never asked, so they never told. Which brings the next question. It is, does your agency encourage assessment of a victim survivor's need for substance abuse services? It's really easy, yes or no, and we can see the full results here. 60% said yes, and 38% says no. Well, this is a great opportunity, to have a conversation with all the advocates when you get together, and talk about this specific matter.
And that's awesome that there's 63% saying yeah.
Yeah,
that's great.
So how do I assess? Well, assessment questions, I heard, very different ways that every single advocate assess. Many women tell me, here's some examples. Many women tell me a way of coping is to smoke, have a drink, or take something else. How often has that worked for you? Okay, so this question actually talks about and makes it normalize the question on, this is something that many women that comes to me that have the same problem that you do are doing, and I understand that this is normal. So the idea on asking these questions is to normalize it and for make this a safe place for them to reveal to you if they're using or they're not using, and how much they're using, how often they're using. if it is working, if it is not working. They will be able to reveal to you if, yes, I'm using, but it is not working for me. It's giving me more trouble. Or, yes, it is important for me. And then we will talk a little bit more about why it is sometimes important for them, specifically in the next question, questions. So sometimes to open the door, to ask these questions, it is to ask about their partner's use, right? And then when you ask, after you ask about their partner's use, you can ask. So many women tell me their partners don't want to drink or use or smoke alone. And this happens very often. So how often do you find yourself using when you really don't want to? Now, if you refuse to use with him, what happens? Many of them, they don't want to use. And I think that a lot of advocates know that a lot of the danger part in a crisis happens when or their partner is using or both are using. So it is important to know what will happen if this is happening in the past. If it happened in the past, you want to know what is he capable of, because if this happens again, you can plan safety around it. So that's why it's so important. The next question is, do you take prescription drugs for depression, anxiety, or nerves? How about to pain relief? Are they still effective, or do you need to take more than prescribed now to feel the effects? How many doctors do you see for these medications? This will tell you also about when you talk about her health, when you talk about their bruises, or if there was a broken bone before, you can open the door to these questions right away. Are you taking some medications? What kind of medications? Is it for depression? Is it for anxiety? Is it for pain? How much are you taking? Are you finding yourself taking more than before? Are you taking more than actually was prescribed? This opens for you a really, really easy door for you to keep going, asking about her use and why she's using. It's about the trauma. It's about her safety. It's about her health. Next question will be, has your substance use changed over the past year or so? And a lot of people will know, well, yes, I'm drinking more, or yes, I'm using more than I want to. So that opens also the door for you to say, hey, well, what do you think? How do you feel about your substance use? Would you like to make some changes? Has anyone else asked you to make these changes? These questions are very important because sometimes they don't connect trauma, domestic violence, and their use with what is happening to her. So they don't make this connection. While you are actually going on and asking these questions, you are actually making her aware that this is a connection and this could be a correlation. And then you can actually explain, well, why is this happening? And this is related to her own trauma. So you are normalizing this conversation. This conversation is not, she will not feel stigmatized by it. She will feel safe with you talking about this specific matters. And then they feel some relief talking with someone that is the ally and not someone that actually is pointing her out to her use as, as a sometimes bad mother, or bad partner, or just, that one. Some people actually just pointing them out, as, I don't know, as a bad human being, right? Which is not. This is stigma. This is stigma.
And all of these questions are available on the second handout that you have, Substance Abuse Assessment for Domestic Violence Advocates.
Well, all these questions that we just talked about are actually somehow managed, around a very important tool that is developed specifically for non-substance abuse professionals, so you can use it. It's really easy it is really easy to remember, and you can actually modify it just to make sure that your client understands the questions. This tool is called CAGE, and CAGE 8. And these are 4 questions. These 4 questions are really easy questions, and your client is going to be able to answer them with a yes or with a no. Now, these are 4 questions. That means that if your client answers with 1 yes, well, the answer indicates a potential problem, okay? It could be just a potential problem. Now, if the client answers with 2 or more yes, it could be that this answer might indicate a substance use disorder. It could be probably that your client has an addiction. These are the questions. Have you ever felt you ought to cut down on your drinking or drug use? Have you people ever annoyed you by criticizing your drinking or drug use? Have you ever felt bad or guilty because of your drinking or drug use? Have you ever had a drink or used drugs first thing in the morning to steady your nerves or to get rid of a hangover? So as you can see, it is cut, annoyed, guilt, and eye opener. So it's in the morning, eye opener. It comes from the very beginning, kind of like, yes, I'm kind of aware that I am drinking too much, and yes, I want to cut down. Or no, I believe that I don't have really a problem with drinking, and I don't think that I need to cut down my drinking. Now, have people ever annoyed you? Some people don't actually feel that anyone is, telling them. But some people will tell you, yes, you know what? They are noticing, some of my friends are noticing, and sometimes when I'm out in the bar or whatever, they're telling me, don't you think you've had enough? Sometimes parents noticed, sometimes their own children, noticed it, and they are the ones that continue telling them. And that's when if they get annoyed, sometimes they start hiding, their use from other people. Guilty before or after. There's a lot of shame and guilt in using. They feel that they are bad mothers, they feel that they should not be doing this. And so in the 4th eye opener is, I started using more often, and now I'm using even in the morning, so I can actually continue my life normally.
It's a withdrawal indicator.
Exactly. It's a withdrawal indicator. It tries to normalize their life, and it is not causing really right there in the morning. When they start using in the morning, it's because it's not that they want to get high or they're happy or they're feeling great. It is actually they're drinking now to feel normal.
And not to feel bad. Absolutely. So when do I assess? Now, this is kind of turned out to be the $10 million question. So when we talk with advocates a lot, I think that there's some discomfort about, okay, great, there's all these questions, but when do I ask them? Do I wait until, we've had this great relationship? Do I ask right away? So here's what we've learned in the work that we've done. And also based on the research that we've talked about so far. So during initial conversations is one strategy. And you can make this as part of your regular routine and that you universally screen. So if you are doing, if you have any sort of paperwork that you have to do for your grant holders or for just keeping a file, you can ask some of those questions that we've talked about as part of a universal screening. You don't necessarily have to document the answers. That's entirely up to you and depends on how you would like to make sure that that information is disseminated to other staff if there is a concern. But making it routine and universal makes it, also normalizes it, that you're recognizing that this is a big issue for the clients that we see. And so that's why we're asking. And we're concerned about your safety, and we're concerned about your health, and we want to do the best job that we can do for you while you're with us. Another time that you can assess is during safety planning. And Silvia's kind of touched on this already, but if there's a couple of things. First of all, if partner is using, we know that lethality goes up, correct? So that is one way to open the door, and that's another bullet down there, is to ask about the abuser's use first. And that one of our team members is an advocate, and she's been an advocate forever, like over 25 years now. And that is her favorite way of opening that door, is to talk about lethality and safety and ask about abuser's use. And then using that screening question about, when we've heard from women that or from our clients, that when their partner is using, oftentimes they have to use with them. How often does that happen for you? And asking the how often does that happen for you is really important, and not saying, does that happen for you? Because it's real easy to say no. But if you say how often, it's normalizing it and saying that, yes, this often happens, and the kind of still say no and still give you a negative answer, but it's a different flavor of question when you ask it that way. And so that's one way of asking about abusers for lethality. And then also, when you are doing, one thing that advocates are amazing at is safety planning and working with a client to find out, because we know that she's the expert and can tell us what's the best way to keep herself and her children safe. However, when you don't assess for substance use disorders or substance use problems, you can safety plan until you're blue in the face, the most amazing safety plan that ever was. But if she is drinking until she blacks out, or she's using until she browns out, meaning like her consciousness kind of comes and goes, that safety plan is not going to be worth anything. It's just going to go right out the window. So it's important to have that understanding about how much they use and when they choose to use, and we are going to talk about a substance use safety plan coming up, so that you know that if, okay, we can do this really intricate, beautiful, whatever safety plan here that's really great, and maybe we need to just par it down for when you choose to use it. These are the two things you need to remember, or this is how you get access to that phone number to get help, so that it's simple and they can remember it very quickly and clearly. When discussing tactics of abuse, we've kind of talked about that too, but we know there's loads and loads of wheels out there, and of course there's a substance use wheel, and so that's one that you can just regularly use when you're talking about power and control. And that wheel in particular really folds in nicely how both his use, or the abusive partner's use, and the victim survivor's use is used when we talk about power and control. Budgeting. Now, this is one that's brilliant that came from advocates that we worked with. There was one advocate in particular that comes to mind that was her specialty, was budgeting and housing, right? So she got a lot of those clients that needed that type of assistance. And she said, look, if you are spending $50 a week on pot, I need to know that. And so she just made a line item for alcohol and other drugs. And talked very openly about, it's not a judgment call. If this is what you need to cope, I understand. But if you're on a fixed budget and I have no idea where your money is going, it's really difficult for me to help you with it, with budgeting and with your housing needs. So that's one way to talk about it. And also, too, as with any other budgeting item, is when you start outlining, like, wow, I am spending quite a bit of my money on drugs or alcohol, that can be really eye-opening as well. And that can be an opportunity to talk with them about, hey, would you like to cut down? Would you like to moderate your use a little bit? Or do you feel like you need to get some support? And then also, just like talking about partners' use first, talking about when women or clients are talking about their concerns for their children, especially children. I met with clients that were as young as 12. So it's not unheard of to talk about substance use in children as young as 12 and up. And if they have concerns for their kids, that's a doorway to ask too about their own use. And how that might be affecting their family. So important rules about assessment. Assessment is ongoing. I hope you know that even if, and during that initial conversation, you did a universal screening and they said, no, 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 no to the cage, there might be something that comes up later. There might be something that is a red flag for you or behavior that seems a little off. And so continuing that conversation and keeping that door open to, this is a safe place to talk about it. I'm concerned about your health and safety, and that's why I ask these questions. Ask early. Now, as we mentioned with our ongoing, our follow-up research project, when we specifically kind of zeroed in on agencies that have done this joint work for a while, what we found was that the clients that said when we were screened early, like in that first or second session, it was very comfortable. It opened the door. We felt comfortable talking about it. It wasn't a big deal to us. And then clients that said they were never asked, they just didn't share. So asking early, asking often, and always framing it around safety and health, and reaffirming confidentiality. I'm sure you are all aware, when victim survivors are involved with a lot of different services such as DHS and other providers, they often will have very open conversations about her use and her activity and treatment. And this is where I see that advocates have an advantage, that you can go in and say, look, things can be very confidential with me. I don't have to tell anyone anything, and this is a safe place for me, for you to talk to me about your substance use and being real honest. So you have that advantage as an advocate, and I hope that you can use that.
Just to add something here, Megan,
yeah.
I just want to remember what Crystal said. Remember the first time in the first of this series of seminars with Barb that she invited a special guest, Crystal, and she was the one also that is actually validating what you're just saying. You know, ask early. She said, I had no problem. I was able to talk about it. And she says, I think that she asked me almost right away, you know, very often, not very early. Very early. She says, and I remember that she mentioned is like, well, kind of like, it wouldn't be, why to ask like 6 months later?
Right.
Right? When actually
it's affecting
me now. Exactly. So I think that she validated what you just said.
Right.
Ask early, ask often, you know. Make it, normalize it, and they will appreciate it.
Yeah, I was so glad that Crystal was able to join us last time. So what do I do with it? So you've asked, and they said, yeah, I do have a problem, or yeah, I do use. So what do I do with that? So here are some helpful responses. This too is on that substance abuse assessment questions handout. And again, so substances can be really effective. Acknowledging, absolutely, they're very effective when it comes to coping with stress or trauma or pain. And then recognizing that this is a coping mechanism that also has its risks, and there might be safer ways for you to cope. Asking what has helped you in the past. Do you want to continue to use? That too, you know, if you have that open, honest conversation about like, where does use fit in your life for you right now, and is this something that you want to continue doing? And if you want to continue to use, what would that look like? They may already be in a space where they're thinking about, yeah, it's starting to get problematic, and so yeah, I'd like to keep it to weekends or keep it to evenings or whatever. So making sure that you have that ability to talk with them about if it were to change, what do you want it to look like? Or maybe they don't want to have any changes at all. Talking, again, linking it to safety, like understanding, yes, this is a coping mechanism, but I'm really concerned about your safety if you continue to use. And have you ever received help before? And would you like to talk to our sister treatment agency? So that too, you're establishing hopefully a connection if she or he is getting some sort of assistance. That might be an opportunity to sign a release so that you can talk with the provider about ways that you guys can work together for her recovery. And then talking to our sister treatment agency. Now, if you don't have, I'm sure you have a treatment agency in your community or an outreach office, but if you don't have much of a connection with them, we have a webinar for that in this series. And so we hope that you come to that and we can give you some strategies to connect with your sister treatment agency. So the substance use safety plan, that is a handout here. I want to kind of stress a few things about it. This does use a harm reduction approach. Not all treatment agencies and not all counselors align with harm reduction. So I want to kind of give you a heads up about that. And what harm reduction is, so most treatment agencies have an abstinence-based program, which means that they ask people to stop using while they're in treatment. And then they also tend to lean towards no use as being the safest use, essentially, that if you don't use, that's what's best for your safety and your health in the long run. Some treatment agencies do use harm reduction if they recognize that people may not have an addiction quite yet, but they need some help in learning how to moderate their use. Or they use harm reduction as a way to reduce their use with the long-term goal of abstinence. And what harm reduction essentially means is that you're admitting that you're going to still use, because that's the reality, that people will continue to use, but you're trying to do so in a way that reduces the harm to yourself and reduces harm to others. So balancing it again around safety concerns. And this is not a safety plan that you would want to use for someone who is active in an abstinence-based recovery. And they're trying to abstain from their use. So if they're sober, you want to talk about relapse prevention strategies as opposed to, and in addition to a safety plan, whereas this is more for folks that might want to moderate or reduce their harm. And if you are unfamiliar with relapse prevention with this particular population, we have a webinar for that in this series that is coming up. So we hope to see you in that one too. Okay, so here's the handout, and I'm not going to read through the whole thing because you guys can print it out and use it, and you're, like I said, you feel free to use it however you see fit. But really, if you read through it, basically they're talking about, if I choose to use, who are safe people and places that I can use around, if I choose to use alcohol around my children, or if my partner chooses to use around my children, how to keep them safe. Or are there safe people that can take care of my kids while I use? If I'm going to use, I need a designated driver, and talking with them about how important that is. Also, the using drugs or alcohol as a coping mechanism for anxiety and depression. We know that if the more you use a substance to cope with emotions, the more likely you are to develop an addiction problem. So it's really important to recognize that, yes, this is an effective coping mechanism, but let's talk about some alternatives, such as exercise or yoga or church or, whatever it is that will help them deal with those big emotions. So yeah, hopefully you'll find some of these useful in your safety planning.
Well, and yeah, coming with substance abuse work required. Yeah.
So this is another thing that has come up a lot in the work that we do, and I'm going to tell you a couple of stories that go along with this. So when I was doing some research interviews, again, this was the follow-up research to that first research project, and I was interviewing an advocate who was just amazing. She was doing such amazing work with her sister treatment agency, and she literally was there like 3 or 4 days a week doing groups with other counselors and meeting with people individually. She was doing amazing work. So if any advocate is going to understand substance use, it's going to be this advocate. Like, she was just really great. So I was talking to her about her work that she does through her office. So it wasn't necessarily in a treatment facility. It was just the outreach work that she was doing with clients in her office. And I asked her, how do you assess? How do you know if that set of clients is using? And she said, oh, no, I don't assess. And I was surprised. And I said, oh, okay, well, for what reason do you choose not to assess? And she said, well, I don't want my clients to think that I think that they're that type of person. And that was a big moment, I think, for all of us on the team, because it spoke to us about, first of all, the motivation behind assessing, that we're not out to get someone, we're not trying to get someone in trouble, that it is about their safety and their health, and that us as ISP, we're not communicating that well enough. And so I told this story during an assessment training similar to this and at one of our sites, and the shelter director came up to me afterwards and she said, Megan, that story just hit me in the gut, because that's exactly how I feel, but I'm telling you that when I ask someone about their substance use, it's like asking a sexual assault victim what she was wearing that night. To me, it is completely victim blaming. And that too, I'm so glad she came up and said that to me, because that too really opened my eyes to, again, that we're not talking about motivation, but we're also not talking about the self-work that comes along with doing this work, because substance abuse is so pervasive that it is very likely that everyone on this webinar today has been affected by someone in their lives or yourself that have had trouble with substance use before. So I hope that you take the time when you start thinking about how you're going to improve services for the clients that you have that also have substance abuse problems, that you take the time to really think about these questions. What are your fears around asking substance abuse specific questions? What are your beliefs about people who use? And really be honest about that. And to give you an honest story, when I started out in this field, as an advocate, I carried a lot of baggage, and I remember a client that we were helping her a lot with money and rent and things like that, and she also was a meth user, and I said, you know what, we need to stop. She doesn't deserve this kind of help. And that was not about her. It was all about my experience with a stepfather that was alcoholic. So really, what are your beliefs about people who use? And what has been your experience with people who use? And do you have concerns about your own use? And finally, what are your options for intervention if your client has immediate safety concerns? This too comes up, that a client comes to your office intoxicated or high, clearly intoxicated or high, and they're driving. So what do you do about that? Who do you call? How do you help them? Or if you're meeting with someone at the hospital and they're drunk still from that night when they were sexually assaulted or whatever, and been in an abusive situation. Okay, I'll turn it to you, Silvia.
Well,
I've got 10 minutes.
Yeah, well, with that in mind, yeah, that's right. But with that in mind, and listening, to a lot of advocates having somehow fears, and I don't want to make my client uncomfortable. I want her to return. I don't want her to run away, right? We just need to know what not to do, okay? And what not to do, some activities that may compromise victims or survivor recovery and safety. It is, first of all, not assessing. We have been talking about the correlation and the numbers, which actually means that if I am an advocate, if I'm in a shelter, I will have 65% of the women that I will see will have a substance abuse problem. So if I do not assess, what can happen? Well, I can actually do more harm by not assessing, okay? Or only sometimes what we want is we want the client or the victim to open it up and bring it up to us. And we know by clients, in the research that they told ISP specifically, they didn't ask, I didn't tell. So that actually is an eye-opening for everyone and for us when we understand that not assessing actually can harm our clients more. When you don't assess, that means that you are not going to ask the questions for substance abuse use safety plan. And if there is not, if that person is actually using, well, lethality can come up and there is more harm for your client. Now, the procedures that fail to conduct safety planning with victim survivors. There is an example here, assessing for use, but not following up with information gathered. So you asked, you said, yeah, you know what, I put in my hat of the substance abuse, and I asked, and she said yes, and I didn't follow up with her. Okay, so what are you going to do with that information? Well, it is the same as if you didn't ask. You ask, you know, now what, right? So that's why it's so important to have a relationship with your sister agency, all right? Now, the next one will be procedures that exclude victim survivors from receiving safe shelter advocacy services. And I think that we saw this in the past. We are actually changing incredibly in this field, and we are not refusing refusing services for drugs that use drugs and alcohol or intoxicated, because we understand that substance use is an illness that these women are using because of coping mechanisms. We are understanding more and more and more, and we are allies to them, and we want them to get healthy and to be safe. So not assessing and providing appropriate services increases the shame and stigma surrounding substance use disorders, and that is so true, Megan. So we do have a couple of examples directly from research. So these are women that were asked, and these are some of the answers that they gave us, right? I felt comfortable with my advocates to talk about my use. From the beginning, they asked. It just didn't seem like a big deal. So if you actually are thinking, oh my God, what's going to happen if I ask? Well, these are your answers. Nothing is going to happen. For them, it didn't seem like a big deal. Go to the first webinar, listen to Crystal, and you'll see it was not a big deal for her. So just make sure you know that you do assess and that you know what to do afterwards, how to ask those questions, and it's really not going to be a big deal for your client. Actually, you are touching a very important part of her life, and you can actually be saving a life. I wouldn't have mentioned my treatment if they hadn't asked. That's what we said, you know. They don't ask, I don't tell. I had no idea that it wasn't my fault until the advocate came to my group. And this was a woman that actually was in a treatment group, and someone from the sister agency, Domestic Violence and Sexual Assault, they did a presentation there. So she came and she was like, he always told me he beat me because I'm drunk. I never thought it was not my fault, you know. And that was a very beginning for her of getting in touch with an advocate. So, and the last one, I don't use, but my boyfriend did. And that's exactly, sometimes actually that's a door that a lot of advocates chooses to do, is ask about the partner's use, and then from there it is an open door, an invitation to talk about her own use. And in this shelter, we just talk about it. You know, it is very open. That's what they think. It is very open. When you talk about things that you normalize about substance use, you make it you normalize it, then it is open to them. They can talk and they can discuss, and they can actually plan for safety. So we were talking about that this is a series of webinars, and as I was telling you, we had a previous one with Dr. Downs and Barb Reynolds, and it's a really good one. If you missed it, go back. I think it's where is exactly where they
mentioned that in the beginning, that it's at the Iowa Coalition Against Domestic Violence YouTube channel. And as Kristen mentioned too, we've got the roundtable discussion coming up next week, and we really would love to see you guys there and talk with you about how we can continue to have this momentum forward. Relapse prevention, building relationships with your community partners, specifically with substance abuse providers, and then policies and procedures. And I also want to mention too, you know, this work, we do a lot of presentations across the state and also the nation, and even done some international presentations. And the work that has been done in Iowa is so unique and very inspirational to a lot of people. So I'm really looking forward to that roundtable discussion to talk about what are our next steps to continuing being leaders in the nation when it comes to this type of joint work.
And I just want to end letting you know that you are the force for them. You are the awareness for your clients. Many of them, they had no clue. They don't make that connection about their trauma, about their fears, about their problems, and their use. They don't make connection about domestic violence, sexual assault. They don't make the connection that this is a correlation and that you're there to help them. You are there to make them safe. Ask those questions, normalize it, and she will be with you, grateful for your courage in asking questions about substance use.
So we have 2 minutes left for questions. So sorry about that. As you can tell, we can really get moving on this and keep talking and talking. So are there any questions before we close?
While we give them a chance to raise their hand or type, I'm just going to mention either in your email already or shortly after this ends, you will be getting an email that has this PowerPoint and the handouts that were mentioned. If you shouldn't by any chance get that, or it went to your junk mail or something, or if by chance you are listening and watching a recording of this and would like them, go ahead and email me and I'll make sure that you get it directly. I'm not seeing any hands or comments. So the other thing I wanted to add is that you'll also be getting an email asking with a link to a SurveyMonkey asking for an evaluation. And of course, you probably know at this point, lots of times funding depends on evaluations. So please it's short, just take a second, fill it out, and that'd be really appreciated.
Yes, we read the survey and we listen to your comments and we try to make changes based on what you have to say. So please do take a moment. We really appreciate it.
Well, we hope that these webinars are going to be helpful to you, that you are actually learning something that you did not know, just like the numbers and the research. And so we just hope to have you here next time. Thank you.
Great. Well, Silvia, Megan, thank you.
Yeah.
And I guess we'll see you next week.
Yeah. Have a great weekend, everyone.
Okay. Thanks. Bye-bye.
Bye.